Well, I've been thinking about what to talk about, and I was vacillating between clinical topic or research, but then after asking a couple of the residents, I figured that some of you may not have seen or attended uh, or are familiar with the research we've been doing in hydrocephalus, and certainly not with the latter part of it from the past year or so. So I figured I'll give you a bit of an overview. It starts out with um, John Holter, who was a machinist whose son had hydrocephalus, and who in the 1950s decided to come up with his own valve because his surgeon had nothing to offer. And the valve changed the world. Before the valve was instituted, the vast majority of children with hydrocephalus died before age 10, and the survivors were developmentally delayed. And after 1958, the vast majority started to survive. So what happens since then? So in the past 60 years, we still have a very high shunt failure rate. We don't know why. Every failure is associated with significant morbidity. And even when the shunt is functional, oftentimes there is morbidity going on, whether it's headache, neurological issues, and of course, lots of frustrations along the way. If you were to buy a car and the car dealer told you, well, just a caveat here is that in a year's time, there is a 40% chance that your car is going to break down and it can't be fixed, you'll have to actually change it. And so put in another $40,000. So under these circumstances, any company who sells these types of cars that are prone to failure would lose their business. It's not acceptable. It's not feasible to have a business model that relies on this. So when you look at the failure rate of the first-time shunt placement being nearly 40% at 1 year, nearly 50% at 2 years, and the vast majority fail within 5 to 10 years, then it makes you wonder. In the era of very high technology, from iPhones to sending missions to Mars, is it conceivable that we don't have a shunt system that can drain CSF appropriately? The one thing that we realize with shunt malfunction is that the vast majority of obstructions are ventricular. It's debris in the ventricular catheter. So Mark went back and did a survey of the ASPN, the American Society of Pediatric Neurosurgery, which comprises all the board-certified pediatric neurosurgeons in the country, and in North America, actually, here in Canada. And he found that there was a 64% response rate, pretty good. But what he found is that nobody had any idea why shunts failed. We knew that there's debris, and we know that there's debris in the ventricular catheter, but there were a variety of different hypotheses as to why this happened. There was absolutely no agreement on what is causing this. The only two things that we agreed on is that the valve type does not make a difference, and the catheter position doesn't seem to make a difference. Our hypothesis in the past few years has been that proximal shunt obstruction relates to chronic shunt overdrainage. The shunts drain, they pull tissue in, the catheters obstruct. Simple hypothesis, but I think that oftentimes major problems come from very simple issues. And I'm going to take you through some of the endoscopic evidence or observations that we've had, which started to make us lean into that direction. So this is a shunt revision with an endoscope. As you know, the majority of shunt revisions that we do are endoscopic, outside the catheter, inside the catheter, navigating in slit ventricles, etc. So that allowed us to make a few observations. And this is the first paper that Mark Kramer published, which showed our observations that when you remove a catheter from the ventricle, what you find is these ependymal bands, these protrusions from the ependymma that line up like a row of trees, in very organized fashion along the catheter holes. And so as we started looking further, we found that actually there are lots of these. In fact, the majority of patients that we've looked at, whose ventricles we looked at endoscopically, had these protrusions. The vast majority obviously came in with shunt malfunction symptoms. However, some of them may not have shunt malfunction and have these protrusions. And so when we started looking at that further, we found that indeed they correspond to these holes. These are immediately adjacent to the holes, and they penetrate the holes. And then if you dilate the ventricles, they go away from the holes. And so when we looked at that in more detail, the question was, what causes them? Is it some overgrowth? Is it some inflammatory reaction to the catheter? Why is it that you're forming these ependymal mounds of tissue? And what we found is that they're related to suction. So this is a catheter that is still in the ventricle, obviously, that's disconnected from the shunt system. And every time that I clogged the catheter with my fingers, allowed it not to drain anymore, the tissue pulled away from the holes. And every time I let the catheter drain with gravity, the tissues penetrated into the holes and occluded them. And what we found is that early on, this dynamic pattern of the catheter, of the ventricle collapsing and then expanding and then collapsing and then expanding, over time stops happening. And what happens is that the tissues become very stiff. And the only way you can get rid of them is through electrocautery. You go in around them and pull them off. This is why you can imagine pulling this catheter to change it. It's going to tear up the ependymma and potentially choroid plexus and cause hemorrhage. So the safest way to remove them is to go outside of the catheter with the endoscope and remove these tissues. And so so early on, there is an intermittent obstruction. Later, they get stuck to the catheters. And then as they got older or more severe, then they actually break off. The suction is so high that they break off into the shunt tubing and obstruct it completely. And in that case, the only way to remove them or to unclog is to change the catheter and dissect it away from these tissues. So in summary, another point. So if you had ventricles that are collapsing around the catheter, that would imply that the ventricles are small. So we looked at that. We said, at the time of malfunction, are the ventricles small? Are they collapsed around the catheter? And we found that here on the left, some of them are, but over here, the ventricles are large. Over here, they're asymmetric, and here they're inconsistent. The frontal horns are small, the atrium is large. And so there's not been any consistency, but it certainly showed that the catheters don't have to be very small. However, if you take these same patients and look at the ventricles when the shunt was actually working, then this is what you see. They all have either uniformly small ventricles, or at least the part of the ventricle that corresponds to where the tip of the catheter is collapsed. So this overdrainage is happening when the shunt is actually working. And then once the catheter occludes, some ventricles dilate and some don't. And then so we looked at the environment of the catheter on MRI scans without a malfunction. So we classify them into 1, 2, and 3. And 3 means the catheter is completely embedded in tissue. 2 means the ventricles are actually still a bit large, but the catheter is adherent to the ependema or the septum pellucidum, like in this one. And then 1 is where the catheter is completely surrounded by CSF. And what we found is that we have had no shunt malfunctions in this class 1 category. So this really is very much like the adult patients whose ventricles never collapse when you shunt them for the first time, because they develop stiffness over time, whereas in children, the ventricles tend to collapse. And this is probably the reason why in adults, the shunts don't fail as much. So these are the results. We've not had any class 1 patients whose shunts fail. So in summary, these ependymal bands, which are due to suction, can be intermittent. So they collapse, the catheter obstructs, the ICP what can we decrease shunt obstruction by decreasing drainage? And this is where Joyce's study came on with help from Mark, and where we started putting anti-siphon devices at least 10 centimeters away from the primary valve. And we can discuss that distance later. It's not very relevant at this point. But these are simple second valves, if you want, that we place in series with the first shunt system. And before these anti-siphon devices came about, we used to use just a regular valve, and it worked just as well. And this is what we found. So in the simple patients, meaning patients who've had less than 10 shunt revisions in their lifetime, in the first year after placement of the anti-siphon device, the 1-year failure rates decreased by 67%, and the 5-year failure rate decreased by 43%. And these are, again, patients who are not used to having a lot of shunt failures. If you were to then look at the subpopulation, there's a small population of patients whose shunts fail all the time. And many of you know many of them. And this is what happened. In the first year, 76% decline in proximal shunt obstruction rates, and this sustained in year 5, where it was down to 66%, nearly 66%, which means that we've really cut down significantly on proximal shunt obstructions, something that there's not been any intervention since the 1950s that has been able to do that. The only exception is an article from Germany from 2000 in the Journal of Neurosurgery that showed that if you add anti-siphon devices separate from the primary valve, you will significantly decrease. They decreased their shunt malfunction rates by 90%. So their data are even better than ours. But this is, there's not been an intervention since the 1950s that decreased shunt obstruction rates by even 5%. So what does that mean? Well, this is Richard. A lot of the young people here don't know Richard, but a lot of my senior partners know Richard very well. Many of them were favorites of Richard's family, like Dr. Dempsey, Dr. Resnick, and Dr. Trost. The bottom line is that in 2008, I placed an anti-siphon device in Richard's shunt. He has two shunts, and I put an anti-siphon device in either. And that was his last shunt malfunction. It's been now 12 years. This is his graduation from high school 3 or 4 years ago. When we look back at the survey that Mark has set up, has completed, we find that less than 5% of pediatric neurosurgeons feel that the majority of their patients have chronic shunt overdrainage. This is not an issue that is established in our field, or and it's certainly a controversial issue. But so less than 5% agree that the vast majority of shunts overdrain. So the question is, what is overdrainage? So overdrainage is shunting more than you need to relieve the hydrocephalus, is the simple definition, and the primary mechanism is gravity. However, when I started collaborating with David Shu, David, as you all know, is a pediatric neurologist, but what he also is a theoretical physicist. So I went to David and said, can you simulate these shunt systems for me? Can we try to figure out what is happening and why? And what he found, which was very interesting, is that overdrainage is not limited to gravity. And in fact, if you look at all the instantaneous pulsatory forces that occur in the brain, all of these drive fluid into the shunt system. For example, if you were to cough, the ICP in your head could go up to 50. Well, the highest pressure valve on the market is 20, maybe 40 if you look at the Certas, virtual off. So fluid's going to go through the shunt. It's not going to go through the shunt only when the average ICP reaches a certain level. It's going to go into the shunt every time you have an instantaneous cough, sneeze, bowel movement, running up the stairs, running down the stairs, or cardiac pulsations. Every systolic pulse way exceeds the opening pressure of a valve, which means that by definition, that valve is constantly open. It doesn't open and close like the companies, feel. So this is a paper that Joyce and Mark are currently completing, and I'm going to take you through some of it. And what I'll show you is an illustration of what this really means. This is Half Moon Bay near San Francisco. And if you look at the shoreline here, the waves break on the shoreline and destroy it bit by bit by bit. So what they've done to protect the shoreline is establish this breaker. They built a breaker where the waves break on the breaker, then the fluid is streamlined and the water goes through the bay without any pulse pressure, if you want. And so the shoreline here would not be affected. So if you think of the valve mechanism, the valve is functioning like this shoreline without a breaker. And every pulse pressure, whether through coughing or any kind of pulsations or cardiac pulsations, is going to drive fluid into the shunt system and drain the brain out. Whereas if you develop a valve that has some kind of a breaker in it, you will be better off. So another illustration is if you look at a dumb valve, which is every valve on the market at this time, which is, let's say, set at the opening pressure of 10. Because of all these instantaneous pulses and because of gravity, nonstop gravitational forces, the pressure it never stays at 10. It goes to the negative range. And the same with the ventricular volume. However, if we were to design a smart valve, which doesn't respond to the instantaneous pulse, it's set in a closed fashion at baseline, but it only opens when the average ICP, without these instantaneous pulsations, reaches a certain level. Then you will be able to achieve an ICP that corresponds to the valve opening pressure. So this is what a smart valve will do, which means it's a valve that responds to average ICP. And the ICP has to, of course, be average every few minutes. Chris Lucio, who is one of the neurologists here, but who's also an incredible engineer and an inventor, has set up and built this valve testing system for us. We do not like the valve testing systems on the market because they didn't bring in all the physiology that we need, such as pulse pressure and gravity. So what he built is a valve testing system that has a pseudo ventricle, that has a reservoir, and where you can change the compliance of the system, just like when you change the compliance of the ventricles. You can change the pulsation, frequency, and pulse pressures, and you can change gravity by increasing the height of the tube. So it has all of these parameters that you can change, but it also has 3 ICP sensors. There's 3 pressure sensors. One here in the pseudoventricle, one before the valve, and one after the valve. So armed with this valve testing system, which resides in an engineering building, we've started looking at the Certas valve. And the Certas valve, we set it at a certain pressure. And what we found is that siphoning indeed leads to greater drainage than expected. And that's independent of compliance and pulsations. And then when you add a valve to the system, it decreases that siphoning, but it doesn't take it away. Okay. Second, when we add pulsations into the system, we found that indeed in the horizontal position, every pulse wave further increases drainage through the shunt system. And that's, of course, mainly in the horizontal position. In the vertical position, gravity is so substantial that it overwhelms the effect of the pulse wave. Then, when we added a valve into the system, it decreases the effects of these pulsations, but again, it did not eliminate them. You still have quite a bit of overdrainage compared to expected. And finally, when we looked at compliance of the pseudoventricle, we found that at low compliance, higher pulse wave increases drainage even more. So imagine those children or now adults who've been shunted since they were babies, and therefore they have no compliance. You've basically dried out their brain. The brain is like a rock. Every pulse wave that happens is gonna drive pretty much all the fluid down the shunt system, and and this is why they're so susceptible to weather changes and to activity and movement and all of that stuff. So the bottom line is that compliance does not affect drainage directly, but the lower the compliance, the more significant the effect of pulse pressures on drainage. Can you guys still hear me? I got a text that I'm disconnected.
Yeah, we can hear you, Danny.
Okay, sounds good. So conclusions are that gravity drives CSF outflow in the vertical position, CSF pulsations drive outflow in the horizontal position, and a bit more in the vertical position. Low compliance increases that pulse amplitude, and these CSF pulsations can be induced by either pathological waves such as coughing and sneezing, or physiological effects such as cardiac pulses. So, which means that understanding shunt function is crucial in the design of future shunt systems. And 60 years after Holter, I think is much too long to wait before an appropriate shunt system is designed. So we took it upon ourselves to form a group of researchers here. We have people from engineering, neurosurgery, and neurology, physics. And we designed this smart valve system that has a flexible antenna that has a sensor which senses ICP, a driver that communicates the sensor information with the valve, and then a mechanical valve which is it has a piezo arm that is closed at baseline, that only opens when the driver tells it to open. All of that can be monitored by an iPhone or PDA remotely in the doctor's office, and it has and the battery is charged remotely by RFID mechanisms. You can within a couple of feet, so you can imagine a battery charger on the pillow at night or something along those lines. These details have not been worked out yet, and we recently started a startup company to try to take that further, because the amount of work that can be done on campus is actually limited and needs to be taken to professional firms. Now, based on this, we actually looked at the market. I mean, do you devise a smart shunt system? Is there enough of a market for this? And if you look at the raw numbers, you find that there is about 120 million shunt business in North America, 90 million in Europe, 400 million around the world. However, when you consider the complications of shunt systems, not necessarily complications in terms of hemorrhage and infection, but how many admissions a shunt patient gets, how many times they come to the ER, how many MRIs or CTs they get, that number becomes way bigger, and there's almost a $2 billion industry behind this. So I worked with a team at Kellogg, and we actually were part of a medtech class at Kellogg Business School that did a market study and what it would take for this type of valve to go to market. And these are the team members. These are all students who came in, either were working at companies before or in business, or they're different. Some of them are engineers, some of them are biotech people, some are MBAs, and they looked at all the facets. And there were 8 teams that were part of this class, and there were 4 judges. So at the end, the judges choose who has the best technology, and 3 out of the 4 judges felt that we had the best technology, even though we came in without a lot of these other technologies. Really had been matured actually over time and were big businesses already. And so that encouraged us to go further. And Tyler Wonke, who used to be a lab student of mine before he went to med school at Northwestern, and in the middle of med school, he started two companies, med tech companies. He became the CEO. He helped start this startup, and has taken it further. And this is the timeline. So final prototyping will take place this year. Benchtop testing will end hopefully next year. There'll be some animal studies. In the past, shunt components have not really been forced to go through animal studies, but I imagine a smart valve probably would. FDA clearance will come soon after that, and all the way to human studies and a CE mark. There are lots of issues that we have to consider. So we had to partner with various firms to try to, and I'm not going to get into details of this, but there were several engineering firms that we have interviewed, and we now settled on a firm called Medox. And we applied for an SBIR from an NSF, and this week we're applying for an accelerator fund from the WRF to fund Medox to take the different components of the valve and make sure that they work properly and make sure that we optimize them and integrate them together. And then there are other corporations that will help us further it along. As far as we can tell, this would be a class device. Hogan Lovells is a regulatory a company of attorneys that actually have been the main firm that got through the FDA 80% of neurological devices in the past 10 years, including 4 of the 5 shunt components that have been approved, and so they've agreed to be our partners with this. And then, as clinical studies come along and animal studies, there are firms such as GCMI T3 here who have done a lot of animal studies for these types of devices and who will help us do it right. And then later, looking at not just FDA approval in the US, but CE mark in Europe. As far as we can tell, and this is really a conservative estimate, is that a shunt procedure in the US costs about $45,000. And you can imagine this is without any complications, which is not unusual with shunt surgery. When we looked at what it would mean value-wise over time, if you take the most conservative estimate, that an average shunt lasts 6 or 7 years, and so you're going to have 4 shunt operations by the time someone in age 9, in his teenage years, having a smart valve, if it eliminates these proximal shunt obstructions, what it would end up needing is maybe a battery change after 7 or 8 years. These numbers are very conservative estimates, and you can imagine we haven't even placed in here all the emergency admissions and the MRIs and the CT scans and the clinic visits for headaches and things like that. And so I'm gonna skip through those slides. The bottom line is that even what you price this valve at seems quite reasonable, because if you have a shunt system that doesn't fail or rarely fails, that is quite a bit of a savings in the future. So we set up the valve as costing $3,500, which is not too far from the adjustable valves that we have nowadays. But I can imagine that this could be even higher if it becomes a successful venture. 85% 90% of the market is 2 companies. So I can imagine that as we proceed through this and get to a certain stage, there may be a time when Medtronic or Integra will come and say, well, we want to, acquire your technology. I think this probably will happen late if when it happens early, they may just take it and shelf it and not take it any further, or they may not have the proper direction to take it to market. Anyway, this is a possible exit strategy in the future. And of course, there's going to be seed funding. So we're working on the first part of that at this time that would allow us to finish a prototype and do benchtop testing and very initial animal studies. In Series A, which is going to require much more funding, there'll be product development and going through the 510K process. And then final animal studies. And of course, human studies are quite expensive if we are told by the FDA that we need it to do that. So going back to our hypothesis, we believe we think we've proven that overdrainage is a major cause of proximal shunt obstruction, which is the primary cause of shunt failure, especially in children. The anti-siphon devices we're using did significantly decrease our obstruction rates, but it will not eliminate it because these systems are still based on gravitational forces. These are differential pressure valves, and therefore a smart shunt system is needed. We've completed the design and have a very simple prototype together, and current work is through additional funding would be to complete the prototype and start real testing. This is the team. So Dave Shu in pediatric neurology and physics, Josh, who's really handled a lot of the engineering work along with our graduate students. Che is here. Mark, of course, and Joyce, who did a lot of all of the clinical work. Chris Lucio, who built the valve, the mechanical valve and the valve testing system. This is Dave Shu's wife, who's also a physicist. John Webster, of course, in engineering. So I'm happy to take any questions. Thank you.
Dr. Kandari, just a quick question for that model that you had shown with the antenna, ICP antenna. How is that detecting ICPs?
So there is an ICP sensor that's implanted in the brain, and which communicates wirelessly with the through this antenna with the device that you have outside of the head. Well, doesn't sound like any more questions. Thank you, everybody.
Thank you, Benny.
Okay.
Thanks, Benny.